So I was going through my channel and I actually realized that the series that has the most views on the entire channel is actually the Bazooka. And it's actually the series that actually made the channel explode. I gave you a poll on the community tab of the channel to ask you guys if you really do miss the Bazooka. And the response was quite overwhelming. And it's clear and evident that a lot of you people missed this series. So I thought I would actually bring it back. Let's talk about the Bazooka. This is season 4, episode 2. Grab a piece of paper and let's go. Hello and welcome to the Bazooka. This is a series on my YouTube channel where we look at 10 OSCE stations in one clinical course. Today we're going to be looking at internal medicine. This is season 4, episode 2. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. And remember that it may contain some graphical images and these are only intended for teaching purposes and nothing other than that. You already know the rules to this series. You may pause the video at any moment. Scream the answer at the screen, write it down on a piece of paper, tell it to a friend. You may pause the video and I do give you the answer in the subsequent slide. So here we go with our station 1. A 50-year-old male presents to the emergency department with a history of breathlessness and cough lasting over a period of 2 years. He also points that he is unable to get dressed recently without experiencing breathlessness. He has a 20-year history of smoking, but no history of hypertension or diabetes. You order for an X-ray and it is shown, as you can see in this image here on the right. Question A. What findings do you note on the X-ray? What is the most likely diagnosis? List 4 other investigations you would order for. You may take your time, pause the video if you may, write down your answer, scream it at the screen, and here comes the answer. But let me give you a background before actually we go into the answer. Remember, this is a 50-year-old man, and they've come in with these respiratory symptoms that are lasting over 2 years. They have come in with breathlessness and cough. So it's already, you can tell that this person has some sort of respiratory pathology. And given that this person has a 20-year history of smoking, this should also be pointing you towards things that you must be looking for on the X-ray. So what exactly do we see? So you have this hyperinflation of the lungs. If you actually count the posterior ribs, we have 1, 2, 3, 4, 5, 6, 7, 8, 9. About 9 posterior ribs that are showing. That usually is a feature of hyperinflation of the lungs. And the lungs just appear larger than they normally do. Also, you have this decrease in the lung markings, especially in the periphery. As you can see, in the periphery, you have this decrease in lung markings. In some x-rays, they may actually even appear darker than usual. We call that as hypertranslucency of the lung fields. And you also have flattening of the diaphragm. So most likely, this patient has a COPD, and most likely they have an emphysema. Other investigations that you'd want to order for include a spirometry or lung function test, arterial blood gases, a full blood count, as well as an electrocardiograph. Moving on to station 2, a 35-year-old patient presents to the outpatient department with a history of vomiting blood. What questions would you ask on your history to help you arrive at a diagnosis? List your questions. So this is the assumption that you are getting an OSCE exam that is projected. I did include stations inside here for an OSCE exam that is not projected in case of a physical exam. So imagine that this one is a projected one. What exactly would you write? So you may pause your video at this particular moment. And here comes the answer. So here's the background of this question here. We get this 35-year-old woman that's having hematemesis, which is the vomiting out of blood, and was asked to actually take a history. So whenever you are faced with these type of stations, if it's a projected one and you're not really physically there, imagine you're actually taking a history. What things would you go through? Remember, when you're taking your history, most important is the demographics of which we are given, the presenting complaint, details of the presenting complaint, meaning the history of presenting complaints. You come to develop your review of systems. You come then to your past medical history, your drug history, your family history. If there's any gynecological or obstetric history which is significant, then your socioeconomic history. A similar schematic is used towards all these history taking stations. So here comes the answer. So what you want to find out details about the vomiting of the blood. What's the duration of the vomiting of the blood? How many times have they vomited? How many episodes? What's the quantity of the vomiters? What's the consistency of the vomiters? Is it frank blood? Is it coffee-colored type of blood? Is there any associated retching before the vomiting? And is the vomiting associated with pain or it's painless? Because all these things are going to be implication on the diagnosis of this patient. And if it is painful, what is the nature of the pain? Where is the pain located? And is there any prior history in the past of this person vomiting, or this is the first episode? Do they pass any duck stool, which is the melena, or is there any blood in the stool, which is hematochezia? Any associated history of abdominal pains, any diarrhea, any anorexia or constipation, any history of weight loss? Does this patient have a personal history or a family history of bleeding disorders, or do they have any bleeding from other orifices, especially nose bleeding or even prolonged periods, given that this is a woman? Do they have a personal history or family history of peptic ulcer disease or gastric cancer? Are they on any medication that can cause bleeding, such as NSAIDs, ASA, which is aspirin, or corticosteroids? Do they have a history of alcohol? If they do have a history of alcohol intake, then how much do they take? For how long have they taken, and what kind of alcohol do they take? Also, do they have a history of binge drinking if they do take alcohol? Is there any history of smoking? If they do smoke, what kind of the substance do they smoke, and for how long have they been smoking? How much do they smoke? So these are the things that are going to be quite important when you're taking such a history. Then we'll come to station 3. A patient comes in with a history of inability to speak and move the left upper limb. Investigations were ordered and an image is shown on the right. What investigation is shown in the image? What abnormal findings are shown? What is your diagnosis? List 4 risk factors associated with your diagnosis in C. You may pause the video at this particular moment, and here comes the answer. So this is a non-contrast CT scan of the brain, as we can see. And remember our normal CT anatomy, this will be the anterior side, this will be the posterior side. This side here, which is appearing on your left side, is what's going to be the right side of the patient. This side that's appearing on the right side of the patient is what's going to be the left side. The right side of you on the screen is going to be, or rather the right side of you on the screen is going to be the left side of the patient. So this patient here has this abnormality here. As you can see, they have this hyperdense lesion in the left side of their brain. As you can see, you have some significant, or it's not really significant, but rather you have some shift of the midline structures. You also have some obliteration of the ipsilateral ventricles and some surrounding edema surrounding this lesion. So most likely this is compatible with a hemorrhagic stroke. Risk factors associated with a hemorrhagic stroke include uncontrolled hypertension, sickle cell disease, bleeding disorders, diabetes mellitus, and some connective tissue disorders. You may also have some rupture of aneurysms that can predispose to the hemorrhagic stroke. Moving on to station 4, a patient comes to the emergency department with a history of severe vomiting and diarrhea for the past 3 days. On further questioning, the patient also points to experiencing fatigue and cramping of the leg. You order for preliminary investigations inclusive of an electrocardiograph, which is shown on the next slide. Question A, what abnormal findings can you see on the ECG? List 2. Part B, what is the most likely diagnosis? Part C, list 3 other causes. Part D, list 3 things you want to do in the management of this patient. So I want you to pause the video. You can write down these questions so that you can keep them in mind, so that I'll leave the ECG on the screen for some time, such that you can keep going backwards and looking at the ECG so that you can know exactly what to tackle with the questions. So please pause the video right now. Take note of the questions. I hope you've taken note of the questions. So I will move now to the next slide where I'll show you the ECG. And I may even zoom in for you so that you don't say that I can't really see. It's too faint, or it's too small, or whatever. Increase the content of, or rather increase the resolution of the video to actually see it much better. I know most of you are probably like, what the hell is going on here? Okay, so if you don't know, then you probably don't know. So let's go back to the questions before I actually come back to answer the thing. So this person has a history of severe vomiting and diarrhea for the past 3 days. That's quite significant. They have a history of fatigue as well as cramping in the similar period, which is also quite significant. When you do your ECG, you're going to be seeing certain abnormal things that are seeing on the ECG. But remember, whenever you're reading your ECG, the first thing that you're looking at is, of course, your demographics of the ECG, which are not really shown on the patient. On this ECG, the things are like the name of the patient, when the ECG was taken, and then, of course, you come now to your rhythm, your rate, your cardiac axis. You look at your PR interval, you look at your P waves, you look at your QRS complex, you look at your ST segment, then you also look at your T waves. Then you can comment that on your ECG. So just by simply looking at this rhythm strip here at the bottom, which is gotten from lead 2, we can almost approximate that our rhythm is somewhat regular because the distance between the QRS complexes is almost equal. I'm just judging this from just looking at the ECG. I haven't really measured, I haven't really gotten a piece of paper, but if you want to be thorough, get a piece of paper, mark this QRS complex, mark this one as well, then move it along this ECG tracing, and then you'll be able to see that it's coinciding for the next subsequent 3 ECG or 3 patterns. Then looking at the axis, lead 1 is facing upwards, lead AVF is facing upwards, lead 3 and lead 2 are also facing upwards, so this person has a normal cardiac axis. But as we can see, there's something that's going on here, especially in these unipolar chest leads. As you can see here, we have the ST segment depression that is much more prominent even here in lead V2. It's also prominent in lead V3. This ST segment depression, as you can see, it's also coupled by the T-wave inversion. So you can see this T-wave is inverted. So this hump that you're seeing here is not really the T-wave. These big humps here, what you're seeing is what we call the U-waves. So this person has the ST segment depression, they have inversion of the T waves, they have presence of significant U waves, and if we actually even look at the PR interval, we can see that the PR interval is like slightly prolonged. You can actually count from the P wave up until the QRS complex over there. So it should be about 3 to 5 small boxes. So it's slightly raised. So the abnormal findings are going to be ST segment depression, you have inverted T waves, you have very large U waves, and you have a prolonged PR interval. Then this is most likely due to hypokalemia secondary to acute gastroenteritis. Other causes of hypokalemia include drugs like potassium-wasting diuretics like furosemide. You also have diabetes insipidus, hyperaldosteronism, also hypomagnesemia. The 3 things you'd want to do, of course, you'd want to admit the patient. You want to get some serum potassium estimation, fluid replacement for this patient, as well as IV potassium supplementation. Coming now to station 5, a patient presents as shown in the image. What is the pathology shown in the image? List 4 investigations you would order to ascertain your diagnosis. What is your most likely diagnosis? List any 2 other features that may be present in this patient. So you may pause your video right now, and here comes the answer. So this is most likely a Dupuytren's contracture. Remember, this is caused by fibrosis of the palmar aponeurosis. Then other investigations are going to be pretty much assessing the function of the liver and the state of the liver. So get abdominal ultrasound, get liver enzymes, which is AST, ALT, and as well as other hepatobiliary enzymes like ALP and GGT. I intentionally included liver enzymes and liver function test in the same sentence to emphasize that liver function tests are not liver enzymes. You can also order for liver function test, serum albumin, serum bilirubin, the prothrombin time, or the INR. You can also order for an alpha-fetoprotein or an alpha-1 antitrypsin deficiency. This patient most likely has a chronic liver disease, most likely secondary to chronic alcoholism. Other features may include things like parotid enlargement, testicular atrophy, gynecomastia, sometimes palmar erythema, splenomegaly, spider nevi, as well as caput medusae. Station 6, which happens to be a physical station now. So this one's your answer must be wholesome and a bit different from the previous station that we had. So a 53-year-old woman presents with joint pain and swelling. Take a relevant history. So I want you now to be writing exactly what you're going to be doing. If you're going to say, hi, my name is whatever, write that. Then I'll tell you exactly the answer in a few seconds. So you may pause the video right now. And here comes the answer. So whenever you're dealing with these physical OSCE stations, remember the first thing you must always do for every station is introduce yourself, greet the patient, gain consent, and confirm the symptoms of the patient. Once you've done this, then you ask when the symptoms first started. Have they progressed or gotten better? Is there any morning stiffness, and what's the duration of the stiffness? Which joints are swollen? Is there any tiredness, fatigue, or malaise? Is there any difficulty in doing chores or activities of daily living? Is there any history of anemia or symptoms of anemia like lightheadedness, dizziness, easy fatigability, palpitations, syncope? Is there any history of weight loss? Is there any history of fever? Any history of night sweats? Does this patient take any diuretics, and does the taking of the diuretics worsen the joint pains or worsen the joint swelling? Is there any history of a rash? Is there any history of abdominal pain or swelling? Is there any history of trauma? Is there any history of red meat ingestion, alcohol, and which causes these flare-ups? Then after you've taken your history, of course, don't forget to take any history of any medication that the patient is taking, any history of gout, any history of rheumatoid arthritis, or any history of SLE in this patient. Then, of course, you thank the patient. Station 7, which also happens to be a physical station, a 25-year-old man comes with a history of generalized body swelling. Take a relevant history. So you may pause the video at this particular moment and scream your answer at the screen, or write it down, or tell it to a friend if you're watching it with a friend for some whatever reason. And here comes the answer. So again, introducing yourself, explaining what you're about to do, gaining consent, confirming the symptoms of the patient. You should ask about the onset of this swelling, any related symptoms like orthopnea, paroxysmal nocturnal dyspnea, shortness of breath, which may indicate cardiac symptoms. You may also have any urinary symptoms. What's the quantity of the urine? Is it the urine appearing frothy? Is there any blood in the urine? Any history of polyuria? Is there any history of yellowing of the eyes? Any history of fever or any symptoms of other infections? Any history of malaria or recent travel? Any history of diabetes? Any history of cardiac disease? Any history of liver disease? Any history of hypertension? Any history of HIV, hepatitis B, as well as hepatitis C? Any family history of a similar illness? And does this patient have any history of malignancy? Do they drink alcohol? And if they do drink alcohol, how much alcohol do they drink? How long have they been drinking for? And then, of course, you do thank the patient. Coming to station 8, a patient presents to you with the following raised lesion on the hand. What is the lesion called? What is the cause of this lesion? List 5 conditions where this lesion is seen. You may pause the video at this particular moment. And here comes the answer. So this is what is referred to as an Osler's node, because remember, Osler's nodes are raised and they're quite painful. Remember, ouch for Osler, meaning it's painful. It's often caused by immune complex deposition, which is going to be resulting in inflammation, and this is going to be causing the redness, the swelling, and the pain. 5 conditions include subacute bacterial endocarditis, systemic lupus erythematosus, disseminated gonococcal infection, marantic endocarditis, and even distal to an infected arterial catheter. Here's the difference between an Osler's node and a Janeway's lesion. Osler's nodes tend to be raised. Janeway's lesions tend to be flat. Osler's nodes tend to be painful. Janeway's lesions are not really painful. Then coming to station 9, a 29-year-old woman comes to the emergency department with complaints of easy fatigability and generalized body pains. You order for a peripheral blood smear and it is shown in the image. What is seen in the peripheral blood smear? What is the most likely diagnosis? List 4 other investigations you would order. Write down 2 complications of this condition. You may pause the video at this particular moment. And here comes the answer. So most likely you're seeing these large immature cells. They're most likely blast cells. So this woman most likely has a leukemia. Other investigations include a full blood count with a differential count, a bone marrow biopsy, reverse transcriptase polymerase chain reaction, which we can do for the BCR-ABL gene. We can also do some certain cytogenetic studies such as fluorescein in situ hybridization tests for the Philadelphia chromosome. 2 complications or features include things like anemia, bleeding tendencies, as well as recurrent infections. Coming to the last station, describe the abnormality in the image. What is the diagnosis? List 2 other signs of this condition that you would look for. List 4 causes of the diagnosis above. List 2 diagnostic tests you would request for. You may pause the video, look at the picture, and write down your answers. And here comes the answer. So this is most likely spoon-shaped nails, and it's most likely koilonychia. It's due to iron deficiency anemia. Other features that you may see or look for are brittle longitudinal ridges on the nails. You may also see brittle or thin and fragile scalp hair. You may see angular stomatitis. You may see a smooth tongue. Causes include GI bleeding, intestinal hookworm infestation, chronic illnesses like the CKD. You may have malnutrition and malabsorptive syndromes. Then 2 diagnostic tests are going to be things like a full blood count as well as iron studies, where you look at the serum iron, the ferritin, the transferrin, and the total iron binding capacity. Now here's a bonus station that I'll leave here, and I want you guys to leave your comments in the comment section below. I will pin the comment that gets the answers correct. The first person to get the answers correct, I will leave it pinned in the comments below. So study the image and answer the following questions. What is shown in the image? What is it used for? What complications are associated with its use? So please have a look at that and write down your answers below. I really hope you enjoyed this episode of the Bazooka. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. Drop a like, drop a comment. To Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.